Some of the things I find interesting about salvage lymph node dissection is if I was going to talk to Dr. Crawford about doing this in my residency, 18 years ago, this would have been heresy. But if you look really carefully at the messing data, and I've seen this in my own patients that have had radical prostatectomy, that there's a small percentage of patients in the randomized trial for ADT that were on watchful waiting. And about 10% of those patients never had a PSA progression, even on active surveillance with lymph node positive disease after radical prostatectomy. So, and we also do surgery routinely in other diseases like ovarian cancer, brain cancer, and of course kidney cancer. That's what we're most familiar with. What are the hypothesized reasons for treating oligometastatic prostate cancer? So optimize locoregional control. So there's those patients that have the pelvic lymph nodes, they get bigger, cause ureteral obstruction. We might be able to avoid that. Maybe we're limiting risk of distant progression, so if we can maybe kind of keep those metastases from leapfrogging, avoiding immediate ADT, which I think is, or for patients that have been on ADT and find it insufferable, that I think that's the most important reason to be considering this, and then potentially improving cancer-specific survival, and I think that needs to be proven. So let's talk a little bit about my experience with this procedure. I've only done 7 cases, which may not sound like very much, but I consider this to be largely a fringe procedure and not very often offered to patients, and it probably still makes me have the greatest experience in the state of Colorado. These are 7 cases in 6 patients. Let me tell you a little bit about this. The first case that I did, I was asked by Mike Lode to remove an FDG PET avid lymph node about 10 years ago in a patient that had castrate-resistant disease. And his PSA was rising. At that time, we didn't have quite so many things that we could do for castrate-resistant disease. And he did have a nice PSA response after his surgery, but that was really just a simple, lymph node removal. We didn't do an extended lymph node dissection. I don't know what happened to that patient in the long run. What I can tell you is pretty typical in these cases is that we do see PSA declines. Those PSA declines, however, are not durable. And any patient I've got follow-up on, pretty much all the PSAs went up somewhere between 12 and 24 months after the surgery. Arguably, probably wasn't doing the lymph node dissection the way they say to do it now, and that is an extended lymph node dissection, but we've been migrating towards that. A couple of situations I also want to talk to, and I don't think people talk much about the cases where maybe we didn't do the best thing for the patient. One was we were trying some heroic surgery on a patient in his 40s that had extensive lymph node disease, and the lymph node was really stuck to his obturator nerve. I didn't think it was worth compromising his leg function for an operation that had dubious utility for that patient. And then I had another patient who had both positive PSMA and Acumen PET scans, although the lymph nodes were not congruent. We removed all those lymph nodes and they were all negative, which was kind of interesting. Let me talk a little bit more about that case. So this is a fella that had radical prostatectomy in 2005 and then salvage radiation a couple of years later. In 2015, his PSA went up to about 6. He started on Lupron, found the symptoms of androgen deprivation therapy to be intolerable. So he stopped about a year later. His PSA, of course, rose again, and he had a C11 acetate PET scan down in Phoenix that showed a PET avid lymph node in the right pelvis. We did a extended lymph node dissection just on the right side in this patient at the time, and 4 of 13 lymph nodes were positive, but his PSA did go down to 0.01 on his 1-month post-op PSA, and so we felt pretty proud about that and happy. And his PSA did gradually increase over the course of about 18 months. He subsequently had a PSMA and an Acumen PET scan, and that showed lymph nodes that were not in the same places, but we went in and removed all those lymph nodes. All were negative. His PSA continued to go up. And they had a conventional CT scan about 6 months later that showed a growing lymph node along the right common iliac artery. And he came back to me again and said, hey, can you do a third lymph node dissection on me? And I said, no thanks. I think we need to start thinking about other things for you, my friend. But, when we talk about pelvic lymph node dissection, at least the way that I do this as an outpatient operation. This can be done robotically. You can send patients home the same day. I consider this to be largely like a laparoscopic cholecystectomy. Somewhere between 1 and 3 hours. Certainly if the patient's had pelvic radiation and the lymph node recurrences are deep in the pelvis, it's going to be a little bit more adventurous and not a resident case. I've largely limited this to pelvic lymph nodes because these patients do have other treatment alternatives, which I'll talk about in a few minutes, and I wanted to largely minimize the morbidity. But I have done one open retroperitoneal lymph node dissection on a patient. This was a very long time ago. his PSA did go down, but subsequently rose again, and that was an open case, and he had a typical 4-day hospital stay. So certainly it's a longer and more morbid procedure. When you look at systematic reviews on the subject, this is probably the best one out there. This was from just a couple of months ago. It was almost 1,400 patients in 27 studies, so about 50 patient study, mostly in Europe, that had PSMA or choline PET scans as the directors for this type of surgery. This is really a hodgepodge of patients, how they were managed, how they were treated both before and after their surgery. So most of them had radical prostatectomy. A lot of them had salvage radiation treatments. These were extended pelvic lymph node dissections generally, so usually about 20 lymph nodes were removed. Mostly there are 5 pelvic lymph nodes. So what I tell patients when I see these scans is for every 1 lymph node you see, there's 2 or 3 that you can't, that are going to be positive, so we need to remove the lymph nodes that are nearby. And then these patients had a mixture of adjuvant therapies afterwards. Follow-up was pretty short, but when you look at the progression-free survivals on these, you're looking at 30-40% at 2 years and maybe 10 or 15% at 5 years, and sort of the typical overall survival that I would expect for somebody with pelvic lymph node disease. Now this was pretty interesting. This was included in that batch of patients. This is radio-guided surgery. So these are 31 patients that had PSMA positive or gallium PSMA positive PET scans and subsequently had technetium, PSMA labeled technetium, or technetium labeled PSMA, and they had intraoperative guidance with a gamma probe. So you actually give this to the patients. They can have an open surgery. You can lay a gamma probe and figure out where the lymph nodes are. Good news is 100% specificity. Bad news is only about 80% sensitivity. So you really still needed to do an extended lymph node dissection in these patients. But this is a good example of what kind of results you can get with an extended lymph node dissection, in that there is a good PSA response, and about 40% of these patients without androgen deprivation therapy, that was part of the protocol, were still biochemical recurrence-free at 13 months. Now, complications I think are important to understand here. Again, there are going to be some. These are the sort of the typical things that you would have when you're operating in the deep pelvis that might have been radiated. Those are going to be lymphoceles and ureteral injuries. And PEs, certainly those are things that you want to try to avoid. So I think limiting morbidity in this operation is really of paramount importance. There has been a risk calculator developed, and of course all the things that you think would make sense to avoid doing this operation are things that would tell you to not do this. And that's if they had high Gleason grade group or retroperitoneal involvement or 3 or more spots, I would not do surgery in those patients. And to be fair, to have SBRT is certainly an option for these patients. Has respectable androgen deprivation therapy-free survival, but a lot of these patients had adjuvant ADT with their procedures, so it makes it a little bit trickier to figure that out, but very low toxicity, so this is a pretty attractive protocol. But most times they're just zapping the few areas that are positive and not doing extended pelvic irradiation. There is a clinical trial out there. This is in Europe and Australia, randomized phase 2, 178 patients. Metastasis-directed therapy could be either surgery or radiation with 6 months ADT, or randomized against metastasis-directed therapy, whole pelvic radiation, 6 months ADT, with a 2-year outcome of metastasis-free survival. I'm going to be interested in looking at that, but I hope a lot of those patients end up having pelvic lymph node dissection. I suspect a lot of them will probably have SBRT. And how much does this really matter when we got theranostics that are coming up? A lot of the patients that have PSMA positive scans are going to have opportunities to have studies like this. So when lutetium or actinium or radioactive bismuth are going to be available, they're going to be candidates for that. However, there are patients that are going to be PSMA negative, unable to get those scans for whatever reason, or are have positive Axumin or choline or acetate scans that I think are still going to be candidates for these types of procedures. So bottom line, salvage lymph node dissection, safe, and I think the most important thing you can do for patients is offer a biochemical response. You can keep these patients off of hormonal therapy for a while. Extended templates are recommended. It can be done robotically, but I really do think morbidity matters, so I've stayed away from doing large open operations. And false positive happens. I think it's still important to try to biopsy lymph nodes, even if you have a positive scan, before you have somebody get treated. And we need better clinical trials.